Coming to the pre-op workup, the most important thing is you should have an appropriate consultation with the patient cardiologist about the patient clinical condition. You should have an access to the whole medical record, what surgery was done or what lesion the patient has. You have to look at the types of surgical repair, what stage is the disease right now, and what was the surgical technique which was employed before. Thorough history and physical examination is priceless in congenital heart disease surviving into adulthood. You should look for signs of congestive heart failure, cyanosis, and compromised peripheral vascular disease. Preoperative echocardiogram is extremely useful in understanding the anatomy and the primary and the compensatory cardiac function. Echo is the gold standard here. Coming to physical examination, the scar might say what surgery the patient might have undergone. If you have the scar just below the clavicle, it might have undergone some electronic implantable devices, which might be a pacemaker or an AICD, automated implantable cardioverter defibrillator, or a CRT, cardiac resynchronization device. If it is in the left second intercostal space, the patient might have undergone a minimally invasive surgery for repair of septal defect, tricuspid valve surgery, aortic valve surgery, or mitral valve surgery. If it is a median sternotomy, it includes all aortic valve surgery, mitral valve surgery, repair of transposition of great arteries, spontan circulation with fenestration, tetralogy of Fallot, central shunt, and even your pulmonary artery binding. And left thoracotomy is usually done for repair of coarctation, ligation of PDA, pulmonary artery banding, and left-sided BT shunt. And usually you will have a chest tube scars which comes in the subcostal place, and the right thoracotomy is done for pulmonary artery binding and right-sided BT shunt. So, with the scar, you can understand what procedure was done for the child. Now, coming to intraoperative anesthetic consideration, here preparation of the anesthetic plan requires detailed knowledge of anatomy and physiology of the lesion. For example, the patient is tetralogy of Fallot. You should exactly know what are the four components of the tetralogy of Fallot and how the repair was done, where the patch was placed, and how the saturation now. So, everything about the circulation, you should have a mental picture of the circulation happening before and after the correction. That is very, very important. And the physiology of the lesion, what is the saturation, how we are going to manage the FiO2, how we are going to improve the oxygenation, those things should come into mind before anesthetizing the case. You should have a proper backup for each of the complications which rise from the circulation. A multidisciplinary team is required for providing optimal management. You should involve the cardiologist, cardiac surgeon, anesthesiologist, and the treating physician. Anesthetic consideration or lesion specific. For left to right shunt, you have one specific anesthetic consideration. For right to left shunt, you have a different set of anesthetic consideration. If patient is cyanotic, it will be different. If patient has pulmonary hypertension, the consideration will be different.